out a few days ago. It's still happening.
It is still happening.
What does it actually mean? Does it mean that there are two different sets of tests that were done? Are we supposed to add the numbers together in order to determine how many tests were done in that period? Or do you follow my confusion? How can you follow my confusion? But do you follow the issue that I'm pointing out there?
I totally follow the issue you're pointing out, and it's the confusing nature of this. Of it, and that's why we are seeking clarification today, because we would want to understand what is really happening.
Yeah.
Now, based on what you see in the figures, and when we started recording cases, we talked about how many of these, beg your pardon, were imported cases. Now there's community spread, no doubt about it. But the challenge also, and speaking to Dr. Michael Owusu, who is a virologist at the Kumasi Center for Collaborative Research, KCCR on Upfront, what he said was that in the lab, based on the symptomatic cases that are brought to them, so priority is given to the symptomatic cases, suspected symptomatic cases.
Right.
I could put it that way.
So that means the ones that come through the hospitals where the doctor determines that this person's symptoms meet the case definition.
Case definition.
Okay.
So once they come in there, they quickly test them. And for those ones that they test, there's a positivity rate of between 16 to 20% or more. And that is the reason why we stopped the pool testing. Because initially we're doing pool testing.
Right.
But the moment your positivity rate exceeds 5%, it means you can't continue with pool testing. And so we have stopped doing pool testing. The other fact, Kojo, is that yesterday, in addressing the press, the Director General of the Ghana Health Service talks about the fact that our symptomatic cases is now 18%. We're recording 18% symptomatic cases. And one of the things I'd like to find out, because...
So of all the cases that come through to be tested, 18% of them are from people who are showing symptoms.
Okay, so of the positive cases, 18%
right. Of those that test positive,
okay, yeah.
18% of them are symptomatic.
Initially, it was 9%.
Wow.
Because initially, we had said that our asymptomatic cases were 91%, and our symptomatic cases were 9%. Now, there's been a 100% increase of the symptomatic case to 18%.
Right.
And the question we need answers to would be, why the increase in symptomatic cases? Is it as a result of we identifying new symptoms of COVID-19? Not long ago, you spoke to Dr. Elikem Tamaklo, who's CEO of the Nyaho Medical Center, and he talked about how he itched, and that was also a symptom of it. And I've just been checking. If you go to the CDC website, they're talking about diarrhea. And also could be a symptom. I like to say could, because not everybody who has diarrhea, has COVID-19. But diarrhea could be a symptom of COVID-19. Conjunctivitis could also be a symptom of COVID-19. But on the Ghana Health Service website, we still have fever, headache, and cough.
So that's not been updated.
No.
Okay. Well, we have to find out why. Maybe it's because the Ghana Health Service do not recognize these symptoms in Ghana. We don't know. But somebody who might know, Dr. John Amwesi, who we talk to so often on these matters, and he always gives us clarity. Dr. Amwesi, it's always great to speak to you. Good morning. How are you? Hello, Dr. Amwesi.
Hello, Kojo. Good morning.
There you are.
And to all the listeners. Yes, how are you?
I'm very well. It's good to speak to you. Dr. Amwesi, of course, is a lecturer in Global Health of the Global Health Department at the School of Public Health, KNUST. He's also the leader of Global Health and Infectious Diseases Research Group at the Kumasi Center for Collaborative Research in Tropical Medicine. We call it KCCR. Dr. Amwesi, so we have questions. The nation has questions. We're wondering what direction we're going in. Is there enough, in the numbers that are communicated to us, is there enough in there for us to get an inkling of whether we are getting back towards normalcy or going away from it?
Thanks for this morning, Kojo, and for these questions. I think it's really critical that we always take the time to reflect on where we're coming from and what that means for our direction and what the future could hold for us. I must be very honest and say that it's very hard to predict where we're going right now and where all this will end, or should I say when all this will end, for a couple of reasons. not only because of what we're doing in Ghana, but also in the larger context of Africa and then globally. Because the nature of this virus is such that you are affected not only by what's happening in country, but also by what's happening all over the world. So in Ghana, if you look at our data, you realize that we seemed to have some kind of a peak at some point, and then things went down a bit and picked up again. And I've always maintained that it's really difficult to use these figures to make any kind of significant projection because of the way in which this data was collected. Typically, if you want to have a very clear idea of the direction in which things are moving and be able to project into the future, you need to be carrying out very systematic data collection, which is aimed specifically at these predictive exercises. If you collect data from hospitals, from health facilities, you do not get the real picture of what is happening in your population. And this is evidenced by the fact that we have widely varying positivity rates, if I can put it that way, in different settings across the country. You would have some offices or some facilities doing a sweep because someone was being contact traced and having 60% of all those who are tested being positive. Elsewhere, you'd have 10% being positive, and so on. And this should tell you that the real picture at the population level is very hard to determine, and you cannot use just what we have from the Ghana Health Service to make a prediction moving forward. And I've maintained over the past 2 months that we do need to set up some kind of a sentinel system, a population-based sentinel system, which goes about doing random tests within the population on a regular basis in order to help us to really measure what our daily incidence rate is and use that to be able to determine where we are going in terms of the direction. You can see clearly that the number of cases has increased significantly over the past couple of weeks. Now, this is not strange at all. It was predicted, and it's exactly what is happening. You see a slight dip over the past couple of days. One may be excited about that, but I may not be so excited about that because I have again maintained that the focus should be less on the numbers of cases, but on two things for me. One is our hospitalization rate, and most importantly, our death rate. Now, why I say most importantly is because if you focus on hospitalization rates, the question would be, what is your criteria for hospitalization? And you know that the more the number of cases or the sicker the people, the further we push away the cutoff for hospitalization. You give priority to those who are the sickest.
Yeah.
So if you have, say, 10 beds and somebody has a cough and somebody has fever, and somebody else has only a cough, let me just say if you have one bed and you have somebody has a cough and fever and somebody else has just a cough, you're going to give that bed to somebody who has a cough and the fever. I'm just putting it in really basic terms. So
right.
That means the person with the cough would go home. So if you use that to measure hospitalization rate, you could make a mistake because also a function of what your availability is. So that's not a bad proxy, but ultimately what you should be looking at is your death rate. And the thing about death is death will not go anywhere. It will always be present. Nobody can contest death. It is the same in the U.S., the same in the UK, and the same everywhere in Africa.
Right.
So the question would be, when we look at our case fatality rate or our death rate in Ghana, what do we see and what can we use this to predict? And this is where I'd like to focus. If you look at our death rate or case fatality rate in Ghana and compare this just within West Africa, I think it's pretty amazing, especially given our testing rate, right? Our case fatality rate is standing at barely about 0.5, as opposed to Nigeria, which is, hovering around, I think, 2 or 3, the last time I checked, and Cote d'Ivoire and others. Even though they're doing a lot less tests per million, way less tests per million than we are. One could say that's a great thing. But I just to be transparent, as a scientist, throw in a caveat there. The question would be, how are we recording our death? How are we labeling our death as being COVID or not? I wouldn't like to think we're doing anything very different from what others are doing, or that there are many deaths that are going below the radar, because there's also another way of catching that, which is looking at your overall all-case mortality rates in the country. So you look at the number of deaths you're having in Ghana for the month of July, the number of deaths you're having in Ghana for the month of June. Backtrack and look at those death rates for 2019 or for 2018, maybe even for 2017. Is there any significant difference between these? So all I'm trying to say is that I would always go for the death rate as the ultimate measure of the direction in which we are moving. Why? Because even if someone is trying to mask the deaths, you can look at your all-cause mortality and look at deviations from that, and use that as an indicator that there could be something wrong. And so far, we are really not seeing this.
Okay.
So my opinion, from the scientific view, is that we are doing much better than our neighbors. Does that mean we're doing well? It's difficult for me to tell, because we could certainly do better, and that's always the thing.
All right, Doc, two questions come to my mind about the death rate. I want us to explore them. The first one is this. You raised that important question as a scientist, whether or not we are properly recording all deaths and properly capturing the number of deaths that are due to COVID-19. And you gave a good example of how we could measure that by comparing to previous years. Has that been done? Do we know what the death rate in June, for example, has been compared to June 2019, 18, and 17? That's really good. No, this has been done. I can tell you. I haven't done it personally, but I know it's been looked at. I looked at some figures a couple of weeks ago, and it really wasn't very different. We are not having a significant increase in number of deaths in Ghana in June last year or last 2 years than we've had this year. Okay, so that means you can even use a very simple, even a simpler index, like looking at the rate at which the morgues are filling up. Yeah. All right. This is not changing significantly. We had the morgue filling up when there was a restriction on the gatherings where people could not hold funerals. Now that is gone, and people can hold funerals. So now that becomes a viable measure also of whether you're seeing an increase in death. In other places, like in South America, one thing that gave President Bolsonaro away was just the rate at which graves were being dug. You see, so we always have to find very innovative ways of being able to have some proximity measures to determine should we be very worried? Are we in a very bad place? I would shy away from saying we are doing great, because that's also dangerous. We're not in a position to really say how well or how badly we're doing, because we're not doing this kind of systematic population level data collection. Right. What we can say is that we are doing better than our neighbors. Okay. All right. So at least we can reasonably assume that we haven't seen a spike in deaths compared to previous years from the numbers that you looked at. We haven't seen that. No spike. That's correct. All right. That's correct. My second question about the death rate. What exactly are we doing as a nation which is resulting in our low death rate? What are the things that we are doing in managing COVID-19 which has caused our death rate to stay low?
I'll tell you one thing, Kojo. My view, or what I think is accounting for our low death rate, is our relatively high test rates. And this is why let me just backtrack a bit and emphasize that, because it's confusing. Why I say our high testing rate is that testing is your only lens, or it's your eyes to see those who are sick. And you can only treat people who are sick. I would like to put it up front that I don't think that in Ghana we're doing anything better than our neighbors by way of infection prevention activities. People are not wearing face masks in Abuja, in Lagos, in Lomé, in Dakar, and in Accra. We're not doing any better. We're not washing our hands any more than the rest of them. We're not doing anything special. All right? We're trying. And we're putting in place all these measures and encouraging people, but we're not complying as we should be, and this is not different in any other countries.
Mm.
However, if you look at the numbers of tests we are conducting per million, it's way, several times over and above what others are doing, all right? And this is reflected in the numbers of cases that we have recorded. Some people argue that the testing rate is not linked to the numbers of cases. Now, this is definitely false. The more you look, the more you see. However, it is not a measure of how well or how badly you're doing, all right? So you're having more cases because we're looking more intently, we're doing more testing. Now, when you test, you're able to identify people and treat them. When you treat them or you isolate them or you make them aware so that their behavior can change and therefore they transmit to less number of people, because even if they don't isolate, they will be to some degree self-conscious and reduce their numbers of contacts, you would end up with less spread and therefore better outcomes because you are isolating them and then you're also treating them. And I think this is what is reflecting in our lower death rate, because we are catching them or identifying them and therefore being able to get them treatment. We were doing a lot better before when we were identifying them early with the enhanced contact tracing, all right? And this is why we had a much lower death rate, because our death rate has gone up a little bit, even though it is definitely much lower than others. It's gone up a little because, yes, our ability to detect them early has reduced because there are many more cases now and we can't keep up. And this is what I spoke about a couple of weeks ago. And this is why I am a bit concerned about the move to focusing the testing only on what we call symptomatic, rather than expanding our testing so that we can keep on catching more and therefore isolating more and therefore treating more, which will impinge on our death rate.
Can I ask about that, if you don't mind? You know what Noguchi has said, that they are now going to focus more on testing the symptomatic cases first. Now, what does that mean? Is that an indication that we are having a bit of strain on our resources? Because you mentioned earlier when you talked about the hospitalization rate, you said that the criteria for hospitalizing people becomes more and more restrictive when we have more and more cases. So when we have more cases, then they will change the definition of who should be hospitalized to be more restrictive. So people with more serious symptoms get hospitalized. So is that what is happening at Noguchi? Are they telling us indirectly, when they say that they will focus more on the symptomatic cases, are they telling us that they are having a strain on their resources because they are doing more tests?
Well, let me just say that I don't speak for Noguchi. I don't work there. So
yes, okay, yes.
Anything I say definitely does not reflect their views or their opinions. But I think it's something natural. It's only what I call the right thing to do. When you have a backlog, when you have limited resources, both in terms of your testing capacity and personnel, you will focus your efforts on where things are worst. We saw this not only, we've seen this not only in Ghana but also in the global north at their peak of the epidemic, where even in hospitals, health workers were being asked to reuse some PPE or to use a limited number of PPEs. Folks were being told to use only gloves and not to wear gowns because they didn't have enough of them. People, health workers in the UK were buying their own masks and this kind of thing because there was a shortage. So when there is shortage, you are compelled to be more restrictive in your approach. I can only think it makes perfect sense that the decision to focus on only symptomatic cases is on account of a backlog, on account of strain and the limited resources. Okay. I think this is only what will happen. But the issue there for me is some clarity on what is meant by focusing on symptomatic cases. And what do we mean by symptomatic cases? And how really different is that from what we have already been doing? Because a symptomatic case is somebody who's showing symptoms, right? And somebody who reports to health facility showing symptoms. But what is the criteria for someone to qualify for a test? Is it every Kwiku and Amma who shows up with a headache saying, look, I have a headache, and headache can be a symptom of COVID-19. Will they get a test? Do you have to have maybe a headache, a fever, and a cough, and maybe a diarrhea before you get a test? I mean, what really qualifies a symptomatic person for a test? And I'm hopeful, as I mentioned last night, that the authorities will be able to come up with some further directions as to which symptomatic persons would qualify for a test. But I'm really hoping that we could expand our testing and hopefully not just limit it to symptomatic people. We have no choice when there are limitations. That's pretty clear, and that's the right thing to do right now. But also what we need to do is to put in more effort to ramp up our testing capacity. Because if we don't do this, we will not be able to quickly identify, let me take the quickly away because we already were not able to do that. We will not be able to identify those who are ill, be able to have them isolated, and be able to provide them with treatment, and therefore keep our mortality rate low. If we only focus on those who are sick, like our neighbors in Cote d'Ivoire and other places have been doing, then we will miss a good number, and then people will progress to severe illness in their homes, those who are also critically ill, and they will die. And
right.
Then we will not like what we see.
Now, you mentioned that one of the reasons why Ghana's death rate is low is because of our higher test rate. Now, at the moment, we have a rather high tests per million rate. If you can remind me, in Ghana, what is our test per million?
Yeah, just a minute. Let me pull that up for you right now.
Okay.
We have currently conducted. Okay, so our test per case is 11.9 tests per case, and then we have just a minute. I think it's going to pull out the right.
Now, I'll explain the reason why I'm asking about that in a minute. Basically, the reason why I want to know what our test per million is because one of the countries that is doing a lot of tests is the United States. Now, it's likely that we might actually have a higher test per million than theirs, but their test per million is 150,804. Okay, and they have a very high death rate, about 7%. We have a 0.5% death rate. That's brilliant.
That's right.
So I'm trying to understand the connection between lots of testing and reduced deaths, and whether it's a uniform trend across the world. So in the United States, they have 150,804 tests per million, but their death rate is 7%.
Yep.
So in Ghana, I don't know if you found the information yet, but in Ghana, I'm curious to know what our test per million is at the moment.
Yeah, I think it comes to about 11,000 per million.
Right.
If I am right. That's what it comes, just about that.
So that's significantly lower, maybe about 10% of the USA's test per million.
That's correct.
But the sorry, I'll let you make your point.
No, please go ahead.
I was simply going to say, but the United States has a 7% death rate. So clearly their higher test per million is not resulting in fewer deaths.
That's right.
Why are we getting that result in Ghana?
Now, I'll explain that. I think it's a really, really great question, and it helps really to put the data into perspective. Now, the reason why I postulated that our test rate is what is accounting for our relatively lower death rate relative compared to others is because you need to look at things at the regional level, right? Ultimately, even with the very poor effort the relatively lower efforts that are being made in the global south, particularly in Africa, compared to North America and other places, you can see very clearly that the overall infection rate and death rate in Africa is low, even with countries who are doing very little or nothing, right? So we're talking about something that is very fundamental. The epidemiology of the disease in Africa is clearly different. So the baseline that we're dealing with in Africa is quite different from the baseline that was being dealt with in Southeast Asia and then in North America and in Europe, right? So if you should extrapolate that to what's happening in Africa, you realize that the picture is not very different, but except that the baseline is very different. Look at the numbers of people who've been affected in Africa. I would say it's very difficult to call that a reliable figure because the rates of our testing overall are very low. But if you look at the numbers of deaths or the changes in death rates across Africa generally, there has not been any massive change in Africa. We're talking about in excess of 7,000 deaths or so across the continent. It's not changed significantly. If you compare that to North America and compare that to Europe, many more deaths. So it's very difficult to transpose testing rates, death rates in North America to testing rates, death rates in Africa and use that to make a case. It's better that we make a comparison within our regional bloc and use that to try to explain what we are seeing. Now, when I made the assertion that our testing rates could be linked to our relatively low death rates, it is just a hypothesis, right? It's a working hypothesis. It doesn't mean that that is actually the cause.
Right,
but
okay.
I'm happy to, engage anybody who would like to proffer something different. And the reason why I focus on the death rate as the subject for the debate is that all the other measures, infection rates, positivity rates, hospitalization rates, are very subject to bias. Even the death rate is subject to bias, but it has the lowest potential for bias, and therefore it's the best base for debate. So this is my hypothesis, that our testing rates are what are accounting for our lower death rates because we're able to identify people who are sick, offer them isolation, and offer them treatment. Right. And it is very clear that early identification, treatment, or an isolation have an impact on the health outcomes of individuals.
Doc, we have a large backlog that we're trying to clear, and as a result, there are some people who wait 3 weeks to get their results. After 3 weeks, is there any value to the results that you will get from your test after 3 weeks? Since if you've not been in isolation, in self-quarantine, you've been going about your business, is there any value to those results? And should we perhaps stop spending money testing samples that are over a certain number of days old?
No, that's another great question, Kojo. So there's two things you need to look at. The value to who? Is it to the individual or to the fight against COVID-19? To the individual, I would say, aside just psychological value, or maybe even less than that, there isn't very much, because 3 weeks post the test being taken, if someone was hardly showing any symptoms, especially over that entire 3 week period, there is really no utility to the individual, except that some people just want to know what the outcome was, and it could just be psychological. In the grand scheme of things, I'll put that very low in priority. I know people who had their test or the sample taken 3 weeks ago, got to know they were positive, and the day they got to know they were positive, they said they had a headache and couldn't work anymore. And then the following day they were just fine. And we know how that goes, and that's fine. But in the grand scheme of things, by way of the national fight against COVID-19, I think it will be very important to still test these samples, because that's the only way we can have an idea of how the disease is being spread. Because the sample was taken for a purpose. It was based on either contact trace or a symptom that somebody was showing. And so if you don't test the sample, you lose the value in knowing the extent to which the disease has spread and the total positives out of the numbers of samples that were taken. Right? As much as possible, you want the numbers of samples taken and number of tests actually conducted to vary just by a very small margin. You don't want a wide variation in that. So I would say if we can store these in a safe way, let's do this and test them when we can, rather than just discard them entirely. Right. Some people may differ in their opinion with this, and it depends on the angle from which you're coming at things. If you're really busy and in a tight situation, this will not be your priority.
Yeah.
So I would say at the individual level, very little utility. At the population level, for our understanding of the spread of the disease in the country, important.
Okay. Would you suggest then, if we are able, that after a certain number of days, those samples should perhaps be deprioritized in the order of getting tested, and that those people should be asked to submit new samples?
I really wouldn't go with asking people to submit new samples. If they had a test taken 3 weeks ago, they had been pretty fine throughout that entire period, and the result only came 3 weeks later, I wouldn't ask them to submit new samples. I don't think there's much utility in that, no.
Okay, so looking at the time that people have had to wait for their results, what would you say would be the cutoff point beyond which those who are doing the testing, like KCCR, Noguchi, and other places, can perhaps deprioritize a sample and test it later? After what point will it lose utility to the person who gave the sample?
When it comes to prioritizing of samples, it involves a number of variables. One, the presentation of the individual, the clinical presentation. How sick is this person? The argument is that if somebody is very sick and is showing all classic signs and symptoms of COVID-19, most likely they would be treated for COVID-19 anyway. So the question would be, when you get to know that the person is positive, you were already treating this person for COVID-19, they were showing the classic signs and symptoms, does that really do anything for the outcomes of the patient? What it might do would be to help you in conserving your bed space in an isolation ward, in an ICU or something. Because if you have someone who's really sick and is in an ICU and turns out to be COVID negative, then you most likely want to move that person out of the ICU. But the argument is that if you got that test result 48 hours later, even, and that person has been in the ICU with COVID patients, then most likely they would have gotten maybe that COVID by now. So it becomes really, really tricky to tackle those balls. The second thing would be, what is the age of the individual? Because we know that people at especially at the extreme of age, aged over 60 and particularly over 70, I mean, as you move higher up in age, your risk increases many more fold for severe disease and for death. That's also where prioritizing samples so that those who are older get their results quicker. But you can prioritize samples by way of the essential services, the police, healthcare workers, and others who need to be at work and might be quarantining because they a suspected case, and you want to know pretty quickly whether or not they can go back to work or should be isolated. You will want to prioritize people who cannot, because of their living conditions, quarantine, and therefore need to be moved to an isolation center. And you need to know this as quickly as possible so they can be moved out of where they are to limit the number of people they come into contact with so that they do not spread. So the decisions regarding prioritization are not limited to just being symptomatic or not. It's a bunch of things. And all this information will have to be collected during the sample collection period and put into an algorithm, and so that you can be put on a priority scale. I do not know if we have this kind of thing in place just yet.
Okay.
All right.
This is how I'd like us to wrap up, Doc. It's a general question about how we're managing the pandemic as a nation. Should we, or do we, let me ask it that way, do we have targets, monthly targets, of how much we want to reduce, for example, the caseload, the cases per day by, or the severe cases by? As a nation managing this, do we have targets from 1 month to the next? Are we aiming towards certain figures at which point we could say, we've got the community spread under control, we can now ease some restrictions? Are we working that way with targets?
That's what we should be doing if we could. And my simple answer to that is I really do not know. The reason why I do not know is I do not work with the Ministry of Health or the Ghana Health Service. I do collaborate with the Ghana Health Service. And I must say the Ghana Health Service has been very gracious and highly collaborative to some of us who work in research, making available to us information, making available to us patients and health facilities so we can do our research. So very collaborative in that sense. But I do not know about any targets that we may have regarding numbers of infections, regarding our reproduction number, which I'll come to again, a very, very important index, which I still maintain we need to go out and measure. So I don't know if we have any targets, but you would have targets when you have a target, you would actually be doing things to determine whether or not you are meeting your target, whether you're exceeding it or whether you're falling short. And I would take this opportunity in this last stretch to reemphasize the need for us to introduce a sentinel approach towards our testing and trying to understand the direction which things are going. This is really the only way we can know the true state of the country regarding COVID-19 and be able to make projections into the future. It may look like we're throwing away money because we're not focusing on people who are sick and this kind of thing, just doing sort of a limited kind of mass testing in selected areas, but it's the only way we can have a true measure. And coupling this with what we call antibody testing, which is being able to measure the degree to which people might have been exposed to me, this would be the single measure which can give us some degree of comfort, some degree of comfort regarding how far this infection has spread. Because if you do your antibody testing and realize that a good number of the population has been exposed or have antibodies, then it gives you some degree of boldness to open up further because, well, people might have the antibodies. The only caveat there is, as yet, we do not know how long, if one has antibodies, they would be immune for.
Yeah.
Is it for 3 months? Is it for 4 months? We cannot tell. But at least in the short term, you can have some degree of comfort. So sentinel tests for identifying the true spread of the disease or the incidence of the disease in Ghana, and seroprevalence antibody testing in Ghana to really determine how many people have been exposed and which would inform the boldness with which we conduct ourselves. And I think moving into an election, this kind of seroprevalence study would be very important to determine how we should do this and would even give the population comfort as to whether they should come out and vote or not.
Dr. John Amwesi, always enlightening speaking to you. We can't thank you enough for your time. Bless you.
Pleasure. Thank you.
Well, there's a lot to think about. 2 very good recommendations coming from the good doctor there. A sentinel system, so we can keep a daily track of what we're doing with the testing and the results. And then antibodies testing being introduced so that we can understand the exposure that the population has had to this virus. Interesting stuff there, Winston.
Very interesting, Kojo, and I like those recommendations. But he also makes a point. I mean, when you asked what we're doing right, something he talked about that caught my attention. The fact that he says, well, we're not doing any better than other countries. And you realize that even when it comes to the wearing of face masks, for instance, many people now get to wear face masks because we're told that because of the law that has been passed and the enforcement of the law. I mean, one of the few areas that we're enforcing our laws very well. And so people are actually acquiring face masks, and also the insistence on some of these things. And he's talked about how, the epidemiology of the virus seems to be different in Africa. And so you could see that in the whole of Africa, about 7,000 deaths. And that's like one country in Europe. But a bit about the attitude, it's got me thinking. The bit about the attitude has got me thinking. Because you see, when Dan Butcher contracted COVID-19, he said he did everything right. Everything that he had been told to do, he did. But he still managed to contract COVID-19. And it will take me to
said the same thing.
That, the health minister said, before he even contracted COVID-19, he said, if you want to die voluntarily, you can do so. But don't add us. And confirm And so the point is, apart from protecting yourself, you should also protect others. So just like a vehicle on the road, you're not just protecting, yourself, but you're protecting other users. And that's got me asking myself this question: as a people, what are attitudes to doing things in this country.
It's fascinating you bring that up. Because there's another thing I was thinking about last night when we were talking about COVID-19 and how it's affecting people's ability to plan.
Yeah.
And how people's businesses are shutting down because of the uncertainty, because of how the virus has spread and their staff are not available and people are not able to come to work. And that is one thing that is damaging businesses. But you see, beyond that, it's the attitude thing you talked about. So many times I've talked to people who talk about how their businesses have collapsed simply because they recruited the wrong people. They employed people who they came along and ransacked their business. People have a certain attitude towards Obifufrejuma. You come along, you get employed, you are taking a salary, but you become the biggest threat to the company because of your attitude.
You see, and this is rooted in history. It is actually rooted in history. It looks like it's been part of us. Look, when we were fighting for independence, it's important to put this. When we were fighting for independence, we had two forms of nationalism. So you had the proto-nationalism. They were asking for fair representation. So I say, I am a Ghanaian. I expect Ghanaians to work within the colonial administration.
Right.
And that will be granted. Then you had the militant form of nationalism. Now, they were the ones who, because at the time, the civil service, all over the world, the civil service is more like the engine of running, the country. There's this proverb, Abanejima Uchunfum. Uchunazi, yes. Now, that kind of mentality. So, in our struggle for...
by the way, let's translate that.
It means that...
government jobs are to be dragged along. Not lifted.
Exactly.
Right?
That's the whole idea. Now, in the struggle for independence, those who were leading the struggle urged these people to deliberately run institutions down.
Wow.
So that it would send a certain signal to the colonial administration that they had to leave.
That's interesting.
You can always find this in history. They actually asked them to do these things. And so for many people, and a proverb certainly tells you the identity of a people. And this is how we have lived ever since. There's so many good Ghanaians who have the right attitudes, but there are equally some Ghanaians who have the wrong attitudes.
Yeah. We've got businesses that are doing well in this country. We do have businesses that are doing great. But at the same time, we have businesses that are failing. People set up organizations, they send money from abroad and they set up a business and they're hoping that it will become another source of income, and then they put the wrong person in charge and things collapse. Today I want us to explore both sides of this conversation. What is it that makes businesses succeed in Ghana? What is it that makes them not succeed? What is it that makes the attitude of the Ghanaian worker become the thing upon which your business's survival will hinge? What are the good examples? What are the bad examples? It's an important conversation, right?
Sure.
People have examples that will shock you. Shock you. Let me share this. Somebody sent this to me. He said, I got 2 motorbikes for delivery, and after a couple of months, the riders felt I had a business running and was making money, which to them was more than what they were bringing in to me. They decided to work and keep the money they made from the sales. For 3 months, regular excuses, police arrest, fault with the bike, their parents sick, children sick, etc. One day I took the bikes from them and sold them. End of story. Had the same issue with an Uber car I got. Spent nearly 15,000, and within 6 months I've only realized 3,000 because the guy felt he had bigger problems and needed the sales to solve them than to give me the money. I took the car from him with lots of faults, had to change the shocks, fix leakage under the car, and sold it. And then he adds one more. He says the last one is very funny. With the things I sell, people sometimes ask why I don't use dispatch riders. Here's the reason. Imagine, on a good day, dispatch delivers items and the people decide to pay cash on delivery rather than send more. The dispatch collecting, say, 10,000 cities will think you have all that money to yourself. Then the demands start. Lend me 200 Ghana. Lend me 500 Ghana to pay fees for my kids. Take it out of my delivery charge I make. Forgetting that sometimes not all the money collected is your profit, but your capital is also part of the money. With time you realize you have to do your own delivery, collect your own money to end all of this. And he says you just can't trust people in the business circle. Is this generally the opinion? Is this generally your experience? Are you in business? What's your story? We'd love to hear your voice. So get ready to call us right after these.
Syndicated Capital introduces the Salad Night range of luxury mattresses and pillows.